Yeah. Hello.
Good evening, sir.
Good evening, Prof.
Yeah,
Good evening, Prof.
Good evening, Prof.
Is the class rep here?
I don't think so, ma'am.
Hello, good evening, Prof.
Sir,
Is
Good
he here?
evening, sir.
good evening, Prof.
Yeah, good evening.
Good evening, Prof.
Yeah. Just to be sure, is it the right time to start, please?
Yes, ma'am. Stop.
Okay.
That's for the time.
All right. So, first of all, I want to introduce the program, even if you've had this earlier on, with respect to the module. This is what we're going to be dealing with. Traditionally over 3 weeks, but now I'm told it's over 2 weeks. So we've put down the course schedule, but the expectation is that at the end of this course, everyone, I mean virtually everyone, understand the entire concept, the goals, the objectives, the function of the health systems, to analyzing health systems, and also trying to see what diagnose issues with various health systems. We in this course as outlined. There is a group project which I had discussed with the class rep. You can as much as 20 in a group. But I'd like to plead with you that there should be no loafers for group. Should be a sponge from the group. That is quite significant that you participate very well. You're going to pick up just one policy, plan, strategy, and do a critical analysis of that policy, plan, strategy. So no two groups will do more than one in that instance. And so you're going to write a report and submit it by the 27th of September. The criteria for marking is also very clear. We want to know how you are able to understand that policy in relation to the nationalities in the class. But I'm told of the number is quite large, but if you are going to write on it, but it's important to put context into what you're writing. And so you follow this because I'm going to mark based on this scheme. So that's what we'll do for the group project. Fortunately, yesterday I couldn't meet the class because of other engagement. And so we'll try the most we can to see how to move as fast as possible today. So in doing that, I will be doing more explanation And then I'll try the most I can to carry everyone along in the class. So that's to put context into how we're going to be working. If not, I go straight to the first lecture, which now questions can be asked by raising yes or putting any query on the chat box. So I'll regularly be looking at the chat box and on the reaction to know if anyone has raised up so hands. At some point, I will pause for us to have some interactive discussion. Please, I want you to seize that opportunity and to air your views. There's almost no right or wrong answer. It's actually a process of understanding how far we've learned and to use that to reinforce knowledge. Okay? So first of all, I'd like you to confirm you see my screen and also I am audible. Can I get that confirmation, please? Yes, each group will write on one policy. So you pick a policy or a plan or a strategy, and you're going to write on that. No two groups will write on the same. Someone said volume. This is about the best volume I have. Is it true that you're hearing me clearly?
Yes, sir. Good evening. Your audio is quite not too loud enough, but I think it's something we can manage. If there's nothing you can do, sir.
Okay. Thank you. I'll try the best I can. All right, so I'll be talking to you about health systems. And now, first, an introduction. Each lecture I'll take about 15 minutes or thereabout talking, and we'll take 5 minutes to have some discussion. Like I did say, I'll do more of explanation, not going through the slide one after the other. So when we look at the word health, for many of us, or all of us, I believe, came from the biologicals, and many of us from even human biology, meaning that you have studied courses related to humans, or at least to biology, whether plant or animal biology. One of the elementary things we learn in biology is that we've got cells. Even if they are content within the cell, but the smallest units, of organization seem to be the cells. And from the cells, you have the tissues. From tissues, you have organs. From organs, you have systems. And systems make organism. So I'd like you to see system in that direction. That is a conglomeration of various organs and tissue working for a specific intent. So if it's an alimentary system, the issue is how to digest, absorb, assimilate, nutrients, into our body. If it is genitourinary system, we know what it does. If it's respiratory, we know also what it does. So also in organization, which comes from organism, you have a conglomeration of systems with specific intention. So countries or global entities can be seen as organization. And so there are subsystems within that organization that helps the organization or the organism, which to function properly. Now, each of those systems have got their primacy. Primacy is the primary intent. And of course, they've got lots of secondaries, a lot of secondary functions, attributions, as the case may be. So when we talk about health systems, we can define it in terms of its primacy, which is health. Now, health, we know from the WHO Chronicle of 1946, is the state of 1948, sorry, is a state of complete physical, mental, social, emotional, and much later included spiritual well-being, and not just the absence of disease or infirmity. I choose my word carefully. So when you look at a state of complete physical, mental, social, emotional, and spiritual well-being, and not just the absence of disease. Now, disease is a state where you have lost equanimity. You have moved from a position of ease to a position of being not at ease. Most times when people know they fall ill, it's because they have deviated, from the normal way they know their bodies. They've got some subjective feelings, that makes them think, oh, something is wrong with me. And then they come down to seek help. So health system in this context now includes all activities, all institutions, and all funds whose primary interest is to improve, promote, or restore health. I want to say that again. You'll find that in the slide as well. Health systems include all the institutions, all the activities, and funds whose primary purpose is to promote its report of 2000. Now, one of the things you have to disabuse your mind about is the fact that when we speak of to the health system, people should not just look at the traditional institutions called the health sector or the health service organization or the teaching hospital or primary health center, as the case may be. These are well part of the health system. The health system goes beyond those institutions to all the institutions, all the activities, and all the funds. Now, the distinguishing features in this is the fact that the primacy will be to promote, restore, or maintain health. Now, take it a little bit further. If a broadcasting station dedicates 1 hour every day to share health information, now the intent of sharing that is to give people the right information to improve, restore, or maintain their health. That belongs to the health system. If a philanthropist has dedicated specific funds to fight against malaria, for the mere fact that the fight against malaria has the primary intent of promoting, restoring, or maintaining health, that automatically becomes a part of the health systems. So we see health system play out in anything, whether it's an activity, or whether it's an institution, or whether it's a fund, so long as the primacy is to restore, promote, or maintain health. Of course, we know that there are secondaries. Just like you see your alimentary system supporting the endocrine system one way or the other, but not that the alimentary system is carrying out the primary function of the endocrine system. It's only supporting. So also we see the health system have so many secondaries in the same way that other systems have secondaries that influence health. Take, for example, a bidirectional link between health and education. Now, what it means is that you need to be healthy in order to learn. Effective learning can take place with people that are healthy. Now, so you can imagine that health system is contributing to education, but that's not its primacy. The primacy is to improve health. And so by having that good health, you are able to study effectively. That does not mean that the educational system is subsumed under health or to ensure that people are healthy. And once people are healthy, they can now learn effectively. You see that play out also between health and productivity. Now, productivity lies in the economic system of any country. Now, you'll find out that for you to be economically productive, you need to be healthy. You know, and sometimes when you become, which I believe you are going to be, public health enthusiast, you possibly may have the Herculean task of convincing policymakers actions. And most times when you go on the platform that, oh, if you do this, there's this quantum leap in the health status, like people say, and so what? But when you begin to tell them, oh, if you do this, people are more healthy to be this economically productive, and this will bring this quantum of resource into our system, and the government will have this kind of revenue, people begin to pay attention to you, you know, not because you have said anything different, you've only touched what is of interest to them. So we see that attribution very clearly among all the systems. Many of you may be aware of the relationship between culture and health. Culture and health. And we know some of the harmful culture and how they affect health. We also know some of the issues of the sociological context. We are talking about illness behavior, health behavior, and how this predicts health, or how certain deviant behavior affects health. So all these are things we know. But the question will now be, what are the boundaries? And what are the other effects, you know, of each of these systems? So when you come down to health, you need to know what health is. I've defined that clearly. You also need to know what healthcare as distinct from health services are. Now, healthcare is a broader term done by everyone, virtually everyone, all corners. But you see, health service deals with the former system, you know, in order to promote, maintain, or restore health. You know, that's a narrower concept. So looking at services generally, it's an essential part of the health system, but it is not all about the system. When we get into the framework, I'll share with you, you know, some of the other pillars or components of the health services of the health system besides health services. But back to healthcare is the fact that this is what many of us connect with when it comes to the health system, healthcare. These are care we know that are provided by people who state or non-state actors have engaged, you know, and they're paid and they are regulated to carry that on. But beyond that, you see lots of care undertaken by people who are called lay carers. This needs special mention because most times we want to know who is doing what in healthcare. We tend to ignore the lay carers because they are maybe relatives or they are not powerful, they don't have a strong voice, you know, and so on. And so it's important to highlight at this point that care is given by so many people who may not be recognized. Some of that time, people help themselves. People have the same condition, they form support group, they form community of practice or experience, community of experience, and they're able to support themselves as self-help groups. So we see this play out. Lay carers do lots of things, including emotional support. We do some logistics support. They also provide information. They make referrals. they do advice, but they do that in rather informal setting. And in fact, in many systems where there is deficiency in those systems, for example, when we say a hospital is more like a residential arrangement where people, once admitted, ought to be cared for until they are fit to be discharged back to their families. But we do know, especially in developing countries, that once people are admitted in hospitals, they get a lot of support from their relatives, either to come in to make sure that the logistics required for their healing, including their nutrition and all that, are provided. So lay carers do quite a lot. And then in many systems now, we see that being organized into a social care system. The world is becoming more around social care, and many of them at this point are paid because they are working as social carers, where we still see a lot of them that are not paid. So if you look at the trajectory, especially the demographic transition, where many countries, especially the advanced, a large population of those who need support, either because they are physically or mentally challenged. You see the industry called the social care, which involves people that are personal assistants or living carers, taking a huge chunk of their budget. So you see all that here. You also see what the health center is, which is an institution where, like a supermarket, you can purchase health services. And they can be primary centers, secondary centers, tertiary centers, depending on the level of sophistication and what they can do. And fast sprouting is the traditional medicine. And the definition of it shows that they are all practices that are done, whether explicable or non-explicable, but are done in order to improve, maintain, or restore health. And so akin to that are the complementary and alternate medicine, which are a diverse group of practice, that are now considered to be part of the conventional health system. In fact, the consumption of alternate medical practice is on the increase in many Western societies. And you see 5 classes of complementary and alternate medical practice, from the acupuncture, that's the AMS, which is the acupuncture and homeopathy. I'm sure you've heard about this, to the mind-body intervention, which includes hypnosis and spiritual healing, to the biologically based therapy, which include herbal therapy and dietary supplements, to the manipulative and body-based method, which includes massage, chiropractic, or osteopathy, then to the energy therapy, which includes energy healing. We've seen this play out, and there is increasingly more consumption of this. Many times these are even non-invasive, and they believe that they offer cure as well as care, that are offered also with orthodox practice. So having described all that in context, we see that people are at the center of all that happens in the health system. Either they are payers, or they are providers, or they are patients, or they are the public. As long as health system is concerned, people matter. People matter. Now, to put this in relative, in context of what countries should be doing, many times people see health as public good. Now, what it means is that a public good is something that should be available to all because it's essential. If you understand the saying, a common saying that the best thing in life should be available to all, just like air, water. Believe that healthcare or health should be a public good, meaning that no one should be left behind in health when it comes to healthcare. But when we come to comparative analysis of various countries' health system, you will see the reality. But let's be idealists at this moment. Ideologically, do you think health should be a public good? In that context, what should be the implication, on our national budget orientation, if we all believe that health will be a public good? The Constitution of the Federal Republic of Nigeria had very minimal content related to health. In fact, a section of that health of the Constitution just says that the government shall provide for the health of the citizen. Thankfully, the country developed a National Health Act 2014, and that brought greater commitment of the government, at least to the aspect of funding healthcare through the basic healthcare provision funds. But we see this play out. How has that worked? Has that provided universal health coverage for everyone? I believe that as public health enthusiasts, you should be a fan of ensuring that healthcare is made available to everyone whenever they need it, wherever they need it, to the extent they need it, without having to feel a pinch of what it takes to have healthcare. You move on to the history of health systems, which is very important, and I've stated quite elaborately on the slide. But I will just dwell on an issue of reforms. Health countries have grown first to establishing national health systems, especially from the 19th century. And establishing national health systems, they have concentrated on building facilities to take care of people who are ill. A common issue around then was the issue of epidemics. Epidemics like the influenza epidemics, the plague, the bubonic plagues, and so on, affect lots of people. So countries need to build big hospitals as isolation facility to be able to separate those who are ill from those who are well. So as a means of controlling the spread of those infectious diseases. The implication is that they had to invest in big hospitals. Now, I've defined hospitals as residential facilities as distinct from clinics, which are ambulatory facility. People walk in and they walk out. So we see that becoming too expensive. Now, the thing about making contingency plan is the fact that even if an adverse event had not occurred, you have to be prepared. All your preparedness should be in place, meaning that the facilities are there, they are manned, a lot of resources are needed to keep those facilities, in the time of peace, let me say, so that when it comes to a time of war, that is when you have the pandemic, it's easy for them to quickly react and do what is needful. So that, comes with a huge cost. So the first generation was looking at those national health systems. And then in the 1950s, up to 1980s, there were observations that some countries did not have to spend that much building the big system. They were investing in cost-effective mechanism, to ensure that they are able to keep their population healthy and not to get to a point where those extreme situations, that will require them to hospitalize people, spend quite a lot of money will come. Countries like Cuba, Costa Rica, South Africa, and so on. And so the world decided that no, there need to be more emphasis on a system that is cost effective. And that was what culminated to the Armor Attack Conference in 1978 that brought about primary healthcare. So primary healthcare appears at that time to be an approach for achieving health for all with a target of the year 2000. And all issues around armor attack and all that is contained in lectures you will learn later. So that began the second generation of reform. From the first generation, which was the build-up of national health systems, building big hospitals and so on, to looking at cost-effective measures of taking care of the health of the people and guaranteeing access to healthcare for all. So the world moved on from there, but there were some issues that were discovered much later. Primary healthcare, as defined and as implemented, was much heavily dependent on suppliers, on technical experts like you and I, with less emphasis on the end users or the would-be beneficiaries. So many a times when primary health centers are built, the end users are not involved. So it becomes a bit of a challenge that the social relevance of these endeavors are not maximized because people are not involved. So the world moved forward to ensuring that people's needs, expectation, preference are required to be able to design systems that works for them. So I'm sure now you begin to hear some of the terms demand-driven healthcare. Sometimes you hear personalized health services or person-centered healthcare, people-centered healthcare, as the case may be. The entire idea is to see that every dollar spent in health is spent around the needs of the people and not around the needs of technicians like you and I. So we see that play out as the third generation of reforms, in health system. While many countries like Nigeria are still grappling to get primary healthcare fixed, the world has moved on. And this generation of reforms requires that, all strategies, all plans are done or revolve around the needs, means that you must capture the needs of the people and make a plan to solve that needs. So in summary, I've talked about the health system with the key concept being health actions and the boundaries being anything done, whether as an institution or activity or funds, with the primacy of improving, maintaining, or restoring health. But in doing that, I've also talked about the relationship between health and other systems within the social context of every country, where they have the primacy, the secondaries. But one of the underlying things that affects every one of them is the issue of responsiveness and fair financing. Responsiveness in the sense that the system should do equally well to everyone, that is meeting the legitimate needs of the population in that regard. Sometimes you may go into a health facility and you are treated nicely. You thank them for that treatment, but the question that comes to your mind is everyone equally treated nicely? So responsible requires that everyone should actually be treated nicely, by that system. And because it's a system, we understand systems operate in environments. Now, this operating environment, which is called the external environment, influences the system. So health system, like every other system, is considered to be an open system because it is influenced by factors from outside. Now, what is within the health system is within their control. their influence. But once it gets outside the system, you have to respond to it. The system responds to it. The system cannot control legislation, cannot control energy. Just less than 2 years ago, about 2 years ago, there were economic changes in Nigeria as part of the current reforms of the government. And that saw the increase in the cost of energy, both from the public source and from the alternate power generation sources. It also saw an increase in a reduction or diminution of the value of the naira, and for an import-dependent economy, an increase in the cost of equipment, commodities that are used to run healthcare. And so what hospitals have to do is just to react and respond to it. No one can circumvent that. So all those things that are happening are part of what changes or the vagaries of the external environment. And so for the fact that it's affecting the operation of the health system, it means that the health system is an open system. There's barely any closed system. Another thought you want to think about is the fact that is it only the so-called health system that contributes to health? We've established earlier that there are secondaries, be it from culture, from economy, from education, that also affect health. But you can also find out what is the contribution of the health system to actual health gain. In this day and age, with statistical analysis, especially the multivariate statistical analysis, we'll be able to establish what exactly is the contribution of various covariates, to an outcome. The outcome in this case could be health status. You can find out what it contributes. And if you look at the global scene, you find out that Africa or sub-Saharan Africa has about 11% of the world population, but accounts for 24% of global disease burden. Now, what it means is that it has a disproportionate share of the global disease burden, but unfortunately has only 3% of the global health workforce and 1% of the financial resources available to health. So this discrepancy contributes to the state of poor health in most countries, sub-Saharan African countries. And so in those countries, you see that health systems are ill-equipped to take care of the present demand, let alone future threats. So in other words, those systems are not resilient. Resilient in the sense that they cannot take care of current challenges, let alone future threats that comes along the way. We're going to look at how does this happen? How does system respond? You understand? How do they contribute, to health outcome? If I go into that, I would want to know if there's any question from anyone. Yes, any hand up? Bam, 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 bam. We want this class to be as interactive. There's time for any hand. Anyone has a question? Okay. I'm going to share another slide with you. Just a minute, please. So, all right, thank you for your time. Maria, you raised your hands up. You may please speak up.
Yes, good evening, sir.
Good evening.
Yes, I picked up from the point, I joined late, I apologize, but I picked up from the point where you were talking about making health a public, that health should be treated as a public good.
Public good, yes.
Okay, yes, so, but my question is, given that the cost of providing health is really high, how can a government ensure that there is equity and equality? And given that households don't have the same income, how do you make it a public good with the kind of costing?
That's a major discourse we're going to be having. How do we make it a public good? And that's when we'll be having a lot of discussion, because that has been the front burner, I must say, for over 40 years globally. And even the current Sustainable Development Plan has that as a major focus, that health should be a public good. So we're going to discuss how that can work in our system. We'll talk about different systems, especially those which have achieved that, either through private investment or through taxation or through social health insurance, or even through community-based health insurance. And we'll see, okay, what can work in our context, you understand? But generally, every country, in a spirit of equity, needs to achieve universal health coverage. Everyone needs to have health care whenever they need it, wherever they need it, and to the extent they need it. And we know the challenges with health, especially issues around externalities. And so leaving it to individuals to cope will be very challenging, And if Nigeria, as contained in its constitution, for example, which says that Nigeria is an egalitarian society, it means that Nigeria must work for everyone, and not just for the president or for those privileged, but for everyone. So we're going to have broad conversation around that and how that can be achieved. So thank you for bringing that up at this point. Let me just share. Yeah, there's no more hand. Check through the no question on the panel. So we want to just check out, when it comes to healthcare, people receive two types of healthcare. One is the personal health services, and this is what is the non-personal health services. These are things that kind of are provided, covers lots of people. Like I spoke about the issue of a radio station. Now the information affects so many people, and this is not considered personal. They have not come to a hospital to come and procure health information. They and they were able to see that. or if you invest in environmental sanitation, good housing, decent and healthy cities, and so on. These are non-personal health services, so they also affect health. Sometimes, like I said, from multivariate analysis, we're able to know what is the actual contribution of health services, to health. Now, on this slide, I brought out a couple of countries in Africa from the east, west, south, and north of Africa. The red line shows Nigeria's indices. Now, on the columns, you have MMR represent maternal mortality ratio. You have on the 5 mortality ratio. Then you have DPT3, life expectancy at birth. Now, everything else life expectancy at birth is an outcome. The other indicators to know how well the system is. So all these are all indicators, measuring maternal, measuring the 5, measuring infant, and then we also have the stillbirth attendant, and then the universal health coverage index from various countries. You see it clearly stated, Nigeria is at 42, only higher than, I believe, Nigeria Republic, and also Chad, but if you look through the indices, the maternal mortality of Nigeria is only higher than that of Chad. And then the infant mortality is even higher than Chad. Is even higher than Chad. The outcome measures. There are also EPs like the workforce. Hello?
Hello, sir.
Welcome back, sir.
Yeah, sorry, I had a poor network. So I'm just walking you through each of the building block contributing, to health outcomes. We could build up that through multivariate analysis. In this case, you can use Pearson's correlation or multivariate statistical analysis or partial outcome measures. And so once you're able to calculate an effect size, you can quantify that effect size. Effect sizes of up to 0.5 and above, and a Pearson correlation coefficient shows large effects, So putting that in context, we can look through the various building blocks and then look at the health outcomes. And there are a lot of possibilities, we can see there, even within the building blocks, there are a lot of interrelationship between one building block and the other. In other words, leadership and governance can affect healthcare financing, affect health workforce, affect medical commodities, affect information, and so also can financing affect all building blocks and so on. So taking not just one thesis on what is the interrelationship between the building block of the health system, without replacement, you see that you will be having at least how many hypotheses do you think you will have just looking only on the area of the building blocks? 6 building blocks, how do they relate with themselves without a replacement? How many hypotheses can you draw out of that? I'm asking the class now. How many? Hello, class. Quick response. How many?
6
Hello?
hypotheses.
How many?
6.
How did you get 6, please?
6 hypotheses, sir.
Sorry? Hello?
Based on the number of building blocks, sir.
There are 6 building blocks, and you want to know how each of them in pairs relate. So in other words, how does leadership relate with financing, health workforce, medical product, information, service? And then how does health financing relate with health workforce, medical commodities, information, service? How does health workforce relate with medical information service? How many relations or hypotheses, we call it, can you draw out from this? I need a smart answer, please. Let me check if
36.
okay.
36.
36. 36.
I'm saying 24, but I just want to know how you got to that.
60.
Huh?
60.
But because we are not going to repeat, so if leadership and health, you can say healthcare, financing, and again. So you have 6 combination 2. What does that give you? Those of you from background in mathematics, 6 combination 2 is what?
36.
6 combination 2. I didn't say 6 permutation 2.
That's 12, sir.
12, sir. 12.
No, it's not 12. It's not 12.
8.
6 combination 2 is 6
It's
times
15, sir.
divided by
It's 15.
360.
15, sir.
15.
That's a smart
15.
answer. 15. So you could see that each of these building blocks interact with themselves, and you could draw up and even conduct at least 15 theses from that. So all you need to do is just go and have secondary data and then put up your correlation or your model, establish your model, and you see the effect of one on the other. But now, if you take it a little bit further to say, okay, what is the effect of each of the building blocks on health outcomes? Now, health outcomes could be any of those outcomes I shared with you earlier whether maternal mortality, infant mortality, child mortality, life expectancy, healthy life expectancy. You'll be shocked to know the contribution of the health system building blocks on health outcomes. Now, one of the ways we look at it is, first of all, what are some of those outcomes? You see them here. And how are each of these building blocks measured? You see a couple of measurements that are used, and these are cuts across various countries. Like you saw the issue of some African countries I shared earlier. So once you're able to get this data, you can do your model, and the model will show you what it looks like. The scatter plot, this is from real data in Africa. It shows that maternal mortality is inversely related to universal health coverage, meaning that the lower the maternal mortality in the country. Are we together, please? Are you hearing me?
Yes,
Prof.
Yes, we are with you, sir.
You're breaking up, sir.
It
You
keeps
see,
breaking,
you
sir.
see the same thing, mortality. And
Not
so it's
clearly.
an inverse relationship. But when you look at life expectancy at birth, you see there's a direct relationship, which means that the higher the universal health coverage index, the vaccination. This is not the exploratory side of the model. You find out that each of these health systems with respect to maternal mortality as an outcome apart from one, which is ODA, Oversee Development Assistance to Research. Now, the more money that flows into your country through grants, aids, as the case may be, the weaker your system. That's one lesson you learn from this. Many ODA driving system happen within countries, and these countries is the piper dictates the tone. And from this 2023 World Health Statistics, you will see that the health system support, the weaker that system. So more money comes in, more maternal mortality. If you look the same way to the fire mortality, the same thing, infant mortality, the lower the life expectancy, now it becomes expectancy is a positive indicator, whereas all other structure or pillars of the health system has positive or direct effect on life expectancy. And all these effects are large because they're, if you look at the adjusted R square in this model, it means that 96.8% of the variance of life expectancy can be attributed by the system building blocks. That the system building block has a major contributor. It's a major contributor or has a major contribution, to ensuring life expectancy. You see all that plays out in this data. Any question at this point? I told you I'll be speaking for you 5 minutes to ask, but if Ganglia Glow, your hand is raised.
Yes, please. Thank you, Prof. Unfortunately, I think the last two slides, all the submissions you're making were breaking on my end. I don't know whether I'm the only one. So it's been difficult to appreciate the full discourse. In fact, around the last two slides.
We demonstrated the fact that the health system contributes significantly to health outcomes. And we went a little bit further to look at how each of the building blocks contributes to the health outcome using specific index as provided for through global measurement or statistics, which was the World Health Statistics. And we're able to make very important deduction to show that, yes, the building blocks contribute significantly to health outcomes. At some point, for negative outcomes like mortality rate or ratio, there is a strong inverse relationship. Apart from one of the index which estimated the total overseas development assistance, to the country. And that's where we saw a direct relationship between that and those negative health outcomes. And I did explain, that current trend with what we know as Trumpism, that is shutting up aid to developing countries is actually an opportunity for developing countries to develop themselves. You understand? And this is what you may know as sustainable development. And when we went to the positive indicators like life expectancy, we saw the same picture, that while all the other building blocks contribute significantly and directly, to life expectancy and healthy life expectancy, overseas development assistance to support the health system has negative or inverse relationship, with life expectancy in the country. So clearly speaking, implication is the same, that what is directed or what is done indigenously, through building the various system building blocks has effects on the health outcomes. And so if you are in a position, you need to ensure, that you look through various building blocks of the health system, not as singly, but as a whole, to be able to ensure that you take all this head on and ensure that the system is strong to be able to guarantee health outcomes. That was what we're trying to demonstrate, okay? And I only beat the gun to be able to tell you when I was discussing the fact that we have personal health services and non-personal health services. And I went on to prove, the health system actually contributes to health outcome. Does anyone have any question based on that? No.
Thank you,
All
sir.
right. Thank you for your audience. Frameworks are important because they help us to understand systems. You still need a framework. So I'll take mentioned the fact that health systems, they can be influenced by external factors, that is external environment. I've also established in a way that there are multiple interconnected factors. Health is multifactorial, meaning that there are so many dimensions and many factors that health. One of the things you see in the slide is that there are multiple dimensions or factors that influence health. In one case, I've used the being as human being, B-E-I-N-G. And so we say the B's are the behavioral factors. And then the logic, and the nutritional factor, G, the genetic factors, and S, services. Services include all services that are available to improve health. And all these are there to ensure that people get healthy. So if you fix one interconnected factors within itself are complex, and they are also adaptive. Complex in the sense that it's most of the times in science we try to look at linear relations, but we understand the complexity science. Under the complexity theory, it's not just a linear relationship, but there is a complex relationship that occurs within variables. This is when you talk about law of motion or Newton's law. One of the things you learn is that for every action, there is an equal and opposite reaction. But you and I know that in reality, to every action, there are multiple reactions. So if you've got a strong positivist mindset, you will think, oh, there's a linear way of looking at things. But if you're a constructivist, which things react. If there is an injury to the vessel supplying a part of your body, the body doesn't just stay on its own, it reacts. So also, once there is an action, there are multiple reactions. And it's only when we are diligent enough, we can be able to examine at least most of the reaction. When I did that experiment with figures, I did say from the R square, from the model, I did say that it means that not 100%, but 90-something% of the variance of the outcome can be explained by the question will now be, what about the others? The others were not identified. You understand? So that's why, and from the constructivist perspective, we see that there are multiple reactions. We try the most we can to get as much factors into our model, to help explain the model. So health systems have multiple interconnected factors. There's non-linearity, meaning that it's a complex adaptive system, And when we had a COVID pandemic, the prediction was that was going to wipe away most of Africa because Africa was considered to have very poor systems, But the reality is now with us. You understand? The reality is now with us that rather than wipe away Africa, countries with stronger health system. what went well for us and what went wrong for them. Could be a discourse for another day. You understand? So what I'm driving at is that some of the theory and the modeling we do may not explain everything, that we see within the health system. So you need to have that at the back of your mind. So I'm going to share very quickly some of this framework. One is the system approach. I've explained this in detail earlier on when I talked to you about the internal environment where the system operates, where the system has got its influence system, because the system operates within the external environment, and so any changes in the external environment, which are things like political factors, security, technology, sociological trend, ecological factors, all these affects the system. So that's how that system operates. So once you look at the traditional health sectors, so to say, within the context of the country or subnational system, you find out that it does not operate in isolation. It operates in a milieu, and that milieu is influenced by everything that pervades the environment in which it is operating. You see that very clearly on that. And I've explained issues around open system and all that. Now, in care delivery, we have the patient-centered framework. This is care delivery. Now, what that means is that the patient is the reason why care is organized. And you have the care team, which includes the frontline health workers and family members. Family members of the patient are critical component of the care team. Many a times we chase them away, but I did say about the 3 generation of health system reform. If you are centered around the patient, it means that everything you do should be ensuring that the patient is as empowered as possible. So the family members are there to support every initiative or intervention that needs to be done for the patient to be pleased to be empowered. So the care team is important. Then the care organization is where care is delivered. Then just like the system model, you see the external environment. Now, the WHO has the World Health Organization has the system building blocks. And this is clearly leadership and governance, financing, workforce, medical product, information, service delivery. 6 building blocks of the health system. So most time we talk about framework, without distinguishing it, we're actually referring to the WHO system building blocks. And this is very important. I'm going to talk more about it in subsequent lectures, but here you will just see brief description of each of the building blocks, each of the 6 building blocks. Then the World Bank, if you know them very well, they try to see what various control knobs, we call them, can have on outcomes, critical outcomes like efficiency, quality, access, And so in that, you have that 5 control knobs, either the financing system or the payment mechanism or the organization of the system or regulation or the behavior of either the patient and the healthcare workers. If you influence any of this control knob, how does it affect efficiency, quality, and access? So within the limit of available resources, you want to maximize efficiency, quality, and access, and that's what the control knob does. I've explained all this on this slide. I've also talked about the contribution of health systems to health outcome, on this slide, and I would be glad if there are any question from anyone, with respect to this. Any question? These slides were actually sent to you ahead of time, and I want to believe that many of you might have read them, or at least had a glance. So this will just be a form of reinforcing not learning. Now, again, I sent slides to you. Yes, I sent a couple of slides.
Hello,
So, yes, please. I'm excited when people ask questions or discuss in class. Even if you don't ask, it makes me feel either no one understood or everyone has understood. Chinedu, please go on, please.
Okay, thank you, sir, for the beautiful lecture. It's actually flowing, just that you're a bit fast for some of us.
Really?
But I want to chip in a quick one.
I thought
I'm sorry.
Hmm.
I find it hard to follow, especially the slides. But I want to ask a quick question.
Yes, go
Is
ahead.
there any difference between the building blocks and the frameworks? And if there are, I would like to know them.
No. If I did explain, if you look at the slide very well, that frameworks help us to understand, a concept. So framework are important for us to use in understanding, in analyzing, concept. So in this context, I brought up a couple of framework for you to understand the health system and components of the health system. Now, from the WHO perspective, the health system building block gives us the full picture of the health system. If you were to talk about health system today, you will have to speak to the 6 building blocks of the health system. That is the structure of every health system. Beyond that, I spoke about if you are to deal with healthcare, which is health services, just one building block of 6, you need to be looking at the patient-centered framework. The patient-centered framework places the patient at the center. The care team, which includes the patient responsible relatives as part of the care team, the care organization, and the external environment. Let's assume because you have an MPH, you're now made to head a health service organization. The system framework will be very important to you. The system framework talks about your internal environment, which is where you have your influence. And you look at the inputs, you look at how inputs are converted through processes to give you the throughput, So that will be now important to you. And let's assume you are going to meet financiers, whether World Bank or local financing establishment. They want to find out, what are you going to do to get certain things? Because they want to see results. Results drives financing engagement. So with that, you now have the control knob. The control knob shows you how, if you change any of those 5 controls, how does it affect efficiency, quality, and access? Efficiency, quality, and access are seen to be earned in this regard. So if you are going to adjust it, let's assume you move from out-of-pocket individual payment to a prepayment system. How is it going to affect efficiency? How is it going to affect quality? So you want to dial the knob to be able to maximize the outcome, in terms of having high efficiency, high quality, high access. That's all I'm trying to explain, so far. But if no one tells you anything, just say, talk about the health system framework. Go to the WHO 6 building blocks and make a show out of that. I see BC's up and Augusta as well. You may please ask your question.
Thank you,
Thank you,
Prof.
sir.
Greetings, Prof. So, in looking at the framework that is patient-centered,
Yes, please.
I also just would like us to take a deep dive into that discussion. Starting with the fact that, the 4 frames, starting with the patient, the healthcare worker, the organization, and the external environment. So,
Mhm.
the goal of this is to ensure that the patient is satisfied. That is, the patient is, goes
Set up.
home.
Yeah.
Yeah. Now, but in order to achieve this, the other two are very critical to I mean, the other three. That is the environment with health education. You can get everybody be informed. With organization, if the structures are in place, that makes it better. Then the healthcare worker is actually where I'm having a lot of issue. And I'm also happy that under the healthcare worker, you have both the trained and the family members. But one thing that we have observed across all our facilities today, especially in the face of the challenge of staff attrition, overall shortage of staff in the clinical sector, our healthcare workers have not really been able to incorporate the effort of the family members into supportive care for patients. I give you an instance. If in the neonatal unit, for instance, we have a practice of KMC, kangaroo mother care. Now, with the presence of the caregiver to carry out the KMC, it goes a long way to help the child, the neonate, to recover faster. That's a part of involvement. So how can we be able to, set up a kind of a policy that, in fact, in many neonatal care now, they are talking about MNICU, that is mother and child, that should not be separated again. This is part of the involvement. But for the older patients, you get to the ward, the way they shout at you, the healthcare workers will chase you out of the ward. If we don't really involve many of these, the family members, the healthcare workers, the trained personnel, will be overworked, they become overwhelmed, and they become unnecessarily harsh to patients because of the volume of work or the low workload that they encounter every day. So there's need for us to have a kind of a look around, involvement of family members in the complete care of any patient. I would like to stop there. Thank you, sir.
Yeah, BC, you are correct. In one of the studies a student did, they found out that patients or patient relatives contribute as much as 60% to healthcare in that locality. Now, what am I saying? They bring the patient down to seek care, and then the health worker wants to see the patient. He say, oh, you need to open a folder. The relative will run down to go and get the folder open. The headquarters sees the patient, makes some decisions without the patient's relative in most instances. No discussion goes on with the patient, so patient participation is zero. Remember when I talked about first the 3 generation of reform, I talked about the third, which means that people should be at the center of everything you do. You can't treat me without, my input. In other words, participation, when it comes to governance, I'll explain more about that, but it's very crucial. Now, many times you see that this go on without people's participation. And so the doctor sees the patient, makes some prescription request for investigation, dumps it there. It is the relation that come to even come and ask question, what did the doctor say? Can we have the prescription sheet or the laboratory request to go and chase those things down? And then, like you rightly said, when the health workers come, oh, leave us, leave us, leave us. You are disturbing us. Who is disturbing who? They have contributed so much. In fact, many systems are a bit, amusing. Everything you do in the hospital, you pay. You go there to open a card, you have to pay. And then when you pay, say, give me the folder I've opened. They showed you the back of the folder and said not to be handled by patient. Wait a minute. Who paid for it? Is it that my information should not be seen by me? You understand? Although those are a cake. I've been involved in designing systems and quality systems in this part. And one of the things we have always hampered about is the fact that patient relatives should be involved. Even if you are in an ICU, give them the right gown and aesthetic procedure. If you're in the theater, they can choose to be there to see what is going on, you understand, with their words. They are part of it. You may need to ask quick decision, depending on what you're seeing at the theater and all that. So participation is key. I'll be talking more about that when we look at governance, within the health system. And this is one of the things that was strictly lacking in the primary healthcare reform, or the second generation of reform, that the third generation is trying to correct. Iro Giogo Augusta.
Okay. Thank you, sir. Thank you, sir, for the lecture. Okay, I have two questions, sir.
Yeah.
In the beginning of the lecture of health system framework, you talked about beings from human beings, and you gave us B is for behavioral factor. I didn't get E and I.
It's environmental. E is environmental.
Then I is what?
I is immunological stroke infective.
Okay. Thank you, sir. Then my second question.
G is genetic, and S is services.
Service. Okay. Thank you, sir. My second question goes to the 6 building block by WHO. Sir, I don't really understand the part where you talked about the hypothesis. You said the hypothesis will be 15. Truly, sir, I don't understand. Like, how is the hypothesis 15? I know you gave us a formula, 6 combination 2, but I'm trying to wrap my head. Is it that each of the building blocks we have 2 or 3 hypotheses? I'm trying to understand. I don't really understand,
No,
sir.
the theory is that we want to see how each of 6 building blocks interacts with themselves without replacement. That is, without repetition. You understand? And so we deduce that we will need 15 relationships. You understand? So if you go by first principle, if that's what you understand, sometimes mathematics can be difficult. It means that if you pick the first building block, which is leadership and governance, it could relate with each of the other 5. So you've got 5, correct?
Okay, sir.
And then leadership and governance goes somewhere to sit. And then you pick the next one. It has other 4 to relate with. You understand? So you pick that up and 4 has gone. 4. That's 5 plus 4. The remaining
9.
4. If you pick the third one, it has 3 to deal with, correct?
Yes, sir.
So when you drop that, you pick the other 4th one, it has 2. You pick the other one, it has 1. So instead of doing all this, mathematics makes it easy. And that will say we now this combination 2. And I realized one of your colleagues actually broke it down on the chat box, if you're observant, and to know what 6 combination 2 is all about. And that is 6 times 5 divided by 2 times 1. And I did emphasize not permutation. If you see permutation 2, you are looking at 6 times 5. But 6 combination 2 means you have to go 6 times 5 divided by 2 times 1. Do you understand? This is not talking about the building blocks. Then I went on further to now say, if you look at a building block on one side, now in trying to do hypothesis, you must have an independent variable and a dependent variable at the minimum. Now, if I take leadership and take health service delivery, I will take leadership as the independent variable and health service delivery as dependent variable. So I want to show how does leadership affect or influence health service delivery. So health service delivery becomes the outcome. But if I have put all the outcomes I want to look at, which I did at some point, looking at mortality in this life expectancy and so on, the building blocks now become the independent variable. And these outcomes, like maternal mortality rate, infant mortality, life expectancy, now becomes the dependent variable. And so we now try to do a multivariate analysis. In those kind of analysis, let me break it down for you to understand. I could look at the building block, which is I could look at leadership and governance on its own, and then maternal mortality on its own. You understand? Now, because I'm dealing with just one dependent, that is called a bivariate analysis. You understand? But anything I get from a bivariate analysis, based on the complexities theory I spoke about, you will say, oh, that give us a total picture. What about the interacting or mediating effect of other things you have not brought into the model? You understand? So when I pick up one dependent variable like maternal mortality, I can feed in all the proxy elements of the 6 building blocks into the same model. By doing that, I'm able to control for that interactive effect, which you agreed would have been formulated by 15 hypotheses to control, so that whatever I see is now a controlled result. Do you understand? So with that,
Yes,
you now see the picture we got, which shows which ones are direct. All of them were significant in any case, but some of them are inversely related, some of them are directly related. And we also saw what proportion of the variance of the outcome can be attributed, you know, to those factors we have fed into the model. And it was very high. 98 point something, which means that if I were you, look nowhere, just concentrate on this factor. If you fix this factor, you get it right. You understand? So some of the lessons you learn is that if you are to advise systems, don't think that just by fixing hospital health system is right. No, it doesn't work. It's too simplistic. You must understand health system as the conglomeration of all these building blocks. And any suggestion you are bringing should look into all the building blocks. Most of the time, the reason why we have failure or partial success in intervention is because we have not considered the entire picture. We want to be simplistic. We want to be politically correct. We want to be just like, oh, somebody says, look, I'm going to build fantastic general hospitals across the state. What about human resource? If you build fantastic general hospital without making a plan for human resource, is it going to work? Obviously not. In fact, the fantastic hospital will become like you know, tourist site where people can say, honestly speaking, it could be dilapidated within a short time, you know, if we do not take it. So in building strategy, which is the first thing you do before a plan, the strategy should ensure that what you are doing will work. As an expert, you must look at your strategy properly. You must do proper forecasting. You know, you must do proper contingency planning. You know, you must do proper benchmarking, you know, and all that before you can go out and talk to government and say, we think this is what's going to work. I wouldn't be surprised some of you are commissioners. You know, these are clear learnings. You don't just think. You are not a magician. Science is simple. There are 6 building blocks. It's been established. So this becomes a model. And if you pick each of them, analyze what it is currently, know where the gaps are, learn to fix them. There's no easy fix in anything. We must be intentional, you know, to grapple with our entire problem. And that is why you see countries which have done very well. They took comprehensive look into their system and decided on that incremental development instead of the quick fixes, which we all run after, especially with our vertical program of verticalization of health actions. It leads no one nowhere, you know, and we have to be very careful about that. Yes.
Thank you, sir. Thank you, sir.
Thank you, Augusta, for getting that clear understanding. I'm sure others would have also learned from it. Looking at the chat box, we seem to be good. Somebody say that's an old chat box. All right, I think we seem to be good, so I can proceed. I have the permission of your class rep to go a little bit beyond 8:30. And I'm sure he discussed that with you guys. But John, I wouldn't go more than 9 o'clock. Huh? All right. So at this point, I would look at the goals and objective of the health system. We've looked at health systems, we looked at the historical aspect of it, we looked at the framework, we're looking at the goal of the health system. When we looked at the health system initially, we said the primacy is health action. And that means whatever is done to promote, restore, or maintain health. So now we look at the goals and we derive the objectives of the system. And then I will show you how to go around some of the contents I have shared with you. And I'll briefly talk on, introduce you to the functions before we leave. So the goal of the health system is to improve health and health equity in ways that are responsive, financially fair, and make the best of most efficient use of available resources. Each of these words very important. Improving health, equity, in ways that are responsive. So I'm going to define what equity means, what responsiveness means, what fairness and financial contribution means, and then what efficiency means in this short discourse. So goals of the health system is number 1, to improve health status. Number 2, to enhance responsiveness to legitimate expectation of the population. Number 3 is to assure fairness of financial contribution. Now, technically, when you look at the health system along this line, health system tries to achieve the highest level of attainment in that system, which we consider to be goodness, as well as the smallest feasible difference between population group, which we consider to be fairness. So on the vertical plane is goodness, on the horizontal plane is fairness. So when I tell you something, I say the health status or the life expectancy of Nigerians is 56 years. What it means is that on the average, anyone born in Nigeria today has a chance to live for 56 years. But you and I know, I'm sure you do know, but I know that there are a lot of social determinants of health. In fact, even currently, we are investigating a lot of commercial determinants of health, such that if you belong to a favorable social strata, the 56 years is just a joke. You can live up to 90 years, comparable to the life expectancy of the best of nations. But if you belong to the lower stratum, then the 56 years is a big achievement. Most people die in their just after birth, or in their first year, or in the first 5 years, or as youth, or as young adults, as the case may be. What that shows is that those measures, which are considered the average measures, do not give you the true picture of how a country is doing. Because we see that there's a wide discrepancy among groups within the country. So health system tries to bridge that. And that is why we said that the goal is in twofold. Get the highest and get the smallest difference between population group. We call that goodness as well as fairness. So if you look at that, improved health, responsiveness can be influenced by the average level and by the distribution. While fairness in financial distribution and contribution, let me explain what it means. A system is said to be fair if everyone in that system contributes based on their ability to do so. That system is considered fair. What do you know as ability? First of all, you look at what do you earn. If you look at what you earn, what do you need for subsistence? That is, what do you need to survive? It includes your house rent, your food bill, your children's school fees, your contributions in taxes, levies, tithe, whatever you call it. If you remove that from what you earn, what is now left is your disposable income. This is the same income you now say, yes, let me go for a luxury goods, or let me go on a holiday, and spend because I've got money. So it means that with that disposable income, having fulfilled the basic necessity of living, everyone should contribute because that's what you now have. But may I tell you that for many people, their take home does not take them home. And so when you are trying to nasty take some money from that or make them spend some money from that on health, you are pushing them into poverty, or if they are already into poverty, you are worsening their level of poverty. Am I communicating? So fairness of financial contribution operates only in the distribution of fairness plane, which is that ensuring the smallest feasible difference among population groups. So if you take this into consideration, we can now say the goals of the health systems are 5. And what are those 5? 1, to improve the overall level of health. Number 2, to improve the distribution of health in the population. Number 3, to improve the overall level of responsiveness. Number 4, to improve the distribution of responsiveness. And number 5 is to improve the distribution of financial contribution. Is that clear to everyone? Now, what I did was that I've created separate slides for health, separate slide for responsiveness. So if you want to know what responsiveness means, it means meeting the legitimate, usually non-health aspects of the population. How is the system oriented towards client services? How does it give promptness to service? How does it take people, respect people? That is, regard someone as a person and not just a case. Client orientation and promptness to service. So there are about 8 indicators you will see there. Your choice to make, your ability to make a choice of provider, the autonomy, and so on. So you see all that stated in my slide on responsiveness. So you must see that the goals now can now be, if I ask you in a theory question, what are the goals? I expect you to speak about 5 goals because you have brought the element of goodness and fairness into it. If I don't see a hand up, I want to believe that everything is clear at this point. Yes. So we look at the objectives. Having spoken about the goals gives you the broadly what health system, is set to achieve. So if you are doing an impact analysis, the impact will be how far has health system met these goals, So if you are, your job is to strengthen a health system, what you try to achieve are the goals. So what you try to achieve are the goals, but what you do to achieve those goals are the interventions. So if you are taking interventions for achieving universal health coverage, ensuring health security, or developing a resilient health system, you are doing all that to be able to achieve the goal of the health system, which is the 5 goals I have stated in the earlier slide. What are the objectives? 6. One is access. Access. The health system is designed to ensure that people have access to healthcare whenever, wherever, and to the extent they need it. In other words, access has several dimensions. Availability is one of it, meaning that the facility or the services are available, within in the area. Affordability looks at the cost element or the financial element in it. Acceptability looks at the way it is designed. Is it acceptable to the people? The geographical proximity is another dimension of access. So when you're looking at access, you look at it through all these lenses, not from a political lens that you say it must be in my village or it must be in my family compound so that we can take the maximum rent from the system. So all these are important. Quality is another objective. Quality is something that's safe, effective, patient-centered, efficient, equitable, according to the Institute of Medicine. Equity is fairness. Equity is fairness. Equity is not equality, but equity is treating equal equally and treating unequal unequally. So you have vertical equity, which means that people who have, let's talk about it in financing, people who earn differently should contribute differently to healthcare. If you talk about it with respect to provision, people who have different needs should have different level of access to healthcare. So the more your need, the more your access to healthcare. On the horizontal equity means that people on the same earning must contribute the same to healthcare. If you're looking at it in terms of provision, people with the same need must have the same access. But we see situations in reality where those who have the most means and by reason of the social determinant of health have less need for healthcare end up having more access to healthcare than those who have least means but have more need for healthcare. And that is part of the failure of health systems in many developing countries. So equity is not achieved in that sense. Efficiency has to do with how we maximize health outcomes with the available resources, meaning getting more from less. There could be technical efficiency, which are a strategy we are deployed to be able to achieve the goal. And then the allocative efficiency is how we have been able to deploy resources, to what we consider to be important, in moving towards the goal. So this needs to be met. Financial provision is how we are able to shield people from the economic consequences of health expenditure. And the slide on fairness in financial contribution, I explained in detail how people can be moved to sell properties, their personal belonging, just to be able to pay for their healthcare. And one of the things you see in that situation is that people experience catastrophic health expenditure. The indices are all on the slide, or they become impoverished as a result of seeking healthcare. So financial protection is very important. And I've described each of these objectives one after the other, in this slide. Access to healthcare, what should be the policy reform, you understand, or what is Nigeria doing, and then quality, what is going on, equity, what is going on. For example, when it comes to equity wants to there is no disparity, among population group, maybe due to social determinants, or like I told you, we're investigating commercial determinants of health. And there are also cultural determinants of health. So if you look at all this, if you look at the Nigerian geographic landscape, you see that there's a huge discrepancy between the north and the south of the country. And even within the north, Nigeria has got 6 geopolitical zones. You find that the northeast, so looking at that, the policy would be, how do we ensure that every area called within the geographic Nigeria components, from geographic to acceptability to affordability, and all that. How do we bridge any deficit that we experience? There are a couple of interventions that agencies have been doing. Like I know last administration, the primary healthcare development agency was into the CHIP project. And this is actually meant, because if you look at the WHO control knob, you see, people have got the health-seeking behaviors, such that even if facilities or services are available, they need to be encouraged, to be able to encourage people, to do the needful, to use available services, go for immunization, go for antenatal care, or seek available help, from the available service. All these are policy directions that need to be strengthened. Efficiency, again, needs to be taken into consideration. And we see that happening, especially when there's so much of fragmentation of the delivery process, usually due to vertical programming. So you see, also when it comes to the issue of health being on the concurrent list, meaning that both at federal, state, and local government you see there are a lot of duplicating roles, even between government and the organized private sector. You see a lot of duplications in their roles, and these have not helped with efficiency, of the system. Financial protection, we see that over 70% of financing is coming out of pocket. Out of pocket means pay as you go. Whenever it's needed, you bring out from your pocket and pay. And so those kind of systems are very unfair, very unfair. And Nigeria has one of the highest proportion of payment of out-of-pocket payments. And then just less than 5% of the population are covered by the social insurance system been in existence for quite some time. And so that has a tendency of pushing those who are already. This is those who move to poverty as a result of health expenditure. As a result of health expenditure. Now there's greater democratization of the social insurance system. States now have the mandate. Before now, insurance was on the exclusive list. It was only the federal government that can legislate and control insurance. But now, states now have the mandate to set up social insurance scheme. The National Health Insurance Agency is now made mandatory for everyone. There are plans to increase the contribution to the basic health care from 1% to 2%. In fact, many states have started doing it. But again, you find out the question will now be, why are we not improving our coverage? With all this. Apart from improving coverage, there is also a lot of under coverage. There was research done by some of our students that found out that even among those who are under the social insurance scheme, there's still catastrophic health expenditure because they pay transport, they take on most of the bills. Now, when you pay a premium, the system exposes you to what are the delivery or even if it contains most of the things you need, they may not be available. And at the point you need them, you now have no other option than to go and source it yourself privately. So all this actually contributes to catastrophic health expenditure among those who are insured, you know. And then you look at, in conclusion, the goals and the objective are interconnected. We'll be discussing a lot about the Nigerian health system in future lectures, seeing how these are operationalized. But for today, I will just explain to you how you can use the other slide. I won't be going so much into it. So if you see 3.1, it talks about how you can improve health. The slide is with you. 3.2 talks about goal 2, which is enhancing responsiveness. And 3.3 looks at financial fairness in financial contribution. So if you can go through it, I assure you, you will understand the very basics of all this so that you know how to engage, you know, if you are in a position to do so, on ensuring that the goals of the health systems are delivered. Is that clear?
Yes.
Yes, sir.
Hello?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
All right. So, all right. Seemed good. Yeah, Vincent, go ahead.
Okay. Thank you, sir, for these enlightening presentations. But my concern is it's how to make a balance, especially when it comes to the social insurance program of healthcare systems. You have correctly described how that the take-home pay of the Nigerian worker cannot take them home, and yet they need to contribute somehow to social insurance to see that to improve the healthcare delivery. How do one create a balance between not having enough and yet still have to contribute? That is my concern, and there are clear-cut case I can relate to when it comes to social insurances in some states that I have privileged information on. The principles are well outlined, but the balance between making contributions where you do not have enough, it becomes where the problem really is. Can you speak to that, sir?
Yeah, like I explained, your contribution should be based on your ability to contribute. Unfortunately, many of the systems we run are not based on sound technical foundation. First of all, on the area of earnings, people have not done analysis of what it takes for someone to survive in Nigeria. Who are paid. The government is trying to correct some of the microeconomic issues with the new tax bill. So by January, you'll find out that the level at which you have zero taxation on your salary as of today is 200,000 naira per year, which is on the average 20-something thousand, or let's say 18,000. In that sense, if you earn 18,000, you don't pay tax. But you and I know that the economy has gone so bad So the new tax bill is going to correct that by the new year. Now, the same thing goes for health. Once you are able to calculate the subsistence, what it takes for people to fulfill basic, and what they have paid, you'll be able to calculate their disposable. It is only for those who have disposable earnings that can now be able to contribute to the system. And until we take that holistic approach into consideration, we cannot have coverage rising substantially in this country. Take, for example, many countries of the world. If you go to Europe, where there are strong socialist tendencies. Now, Nigeria is not, it's not clear whether we're a capitalist country or a socialist country. We seem to vacillate between the two, depending on how, but I think we are largely socialist in nature. Now, what plays out in those systems is that for those who have not, the system enrolls them under Social Security for them to have benefits. Now, these benefits are calculated at what they need to live, to survive. So if the system is giving you $2,000 every month and a house, it shows that $2,000 is enough for you to live. And in that situation, you are also giving health care. You understand? Now, until we get to that point where we are able to calculate and know, it will be difficult. Now, even in that system, like in the UK, if you have got a long-term condition, the system already knows that you'll be burdened. Long-term conditions put a strain on people's resources. Are you aware in current day Nigeria, if you're a diabetic on the A line of drugs, you will spend close to 60, 70,000 naira every month on drugs. In fact, I've even seen a case because in addition to being a diabetic, he has had a Whipple's procedure which removed the major part of his pancreas. So apart from the fact that he's insulin deficient now, he's also glucagon deficient, adrenal deficient, and so on. So you have to supplement. Such people basically will spend 300,000 a month to supplement all the essentials that they need. Now come to look at it. If you are somebody paying or being paid 200,000 naira and you need 300,000 naira to survive, it's not going to be possible. And when we start our discourse, you see that's why it will not be possible even with private insurance. Private insurance are there to make money. Profit is the bottom line. And so if you allow them to operate as a means of achieving universal health coverage, they will tell you who they are going to enroll. They are going to cherry pick those who they are going to enroll. And I can tell you the rule. Take those who have the box and don't have health problem. So that when you take them, they pay you the box, they don't make any demand. The moment they come and say, look, I've got a health problem, I now have dementia, or I now have hypertension, they will skyrocket the premium so that they get more from you to be able to pay for your bills and still make profit. So they don't consider the effect. The key effect with a social insurance system is the effect of cross-subsidization. In that effect, the rich who do not seek so much healthcare pay more for the poor who deserves or demands more healthcare. Are you understanding what I'm saying? In other words, the healthy rich is subsidizing the sickly poor. But social insurance don't want to consider that. So the more pooling you have in the system, the more the rich people contribute so much money because they're earning so much and they don't require so much healthcare. And so what they are contributing is now used to subsidize health services for the poor. That is the beauty of pooling. and of social insurance. That is lost. So because we don't have a strong technical foundation to look at what people earn and what they need on the one hand, we also do not have what it takes to calculate the actuarial. What are the things what is the cost of healthcare on the average? So that you will be able to budget to say, okay, if we are going to achieve universal healthcare through a combination of the basic healthcare provision fund, which is a statutory deduction from the consolidated revenue, and then add on the budgetary aspect again, and add on the social contribution, and add on those who want to get into private insurance. If we pull all this together, what else do we need based on an actuarial analysis that the possibility of falling ill at each age is this, and the cost of treating each episode of this illness is this. So we need this amount of money. And so we want to see how to warehouse that amount of money to be able to secure or grant financial health protection for all the citizens. It's not rocket science, but this is not achieved in many places in Nigeria. I can tell you for free. You understand? And that is why you are building capacity, because many of you end up reforming such system to make it work through what you have learned. All right? Can I go on?
Yes, sir.
Thank you.
Yes.
So there seems to be a hand, but I don't see the hand. But it shows that. Oh no, I think it's just an applause. I'm not sure what that means. I'm only doing my job. So functions of the health system. Now we've talked about the goal. We talked about the objectives. And so looking at the function is more like telling you, just like you have the system building blocks, what are the structural requirements to run? I believe that the system building block gives you a better description of what the structural requirements are to run. You understand? But generally, we pick 4 out of them and say, oh, these are functions. These are things the health system is there to achieve, or they do regularly. Stewardship is governance of the system. Governance of the system. Health systems governance largely depends on government. The public, which is government, has the sole responsibility of organizing the health system. So when government does this by regulation, creating a level playing environment for people to operate, ensuring that it gathers information that can be used for decision making, ensuring that consumers are protected, and all that. So without government effort, in fact, it is said that a poorly financed, poorly managed health system does more harm than good. So in other words, can be very destructive. Healthcare operates as a system that if there are no checks and balances, a lot of things will go wrong. You have been practicing on your own. How many times have the government or the system come to audit what you've been doing? Without those checks and balances, a lot of things can go wrong in the system. And since health system is an open system, part of the expectation would be that, improve system and also to ensure that people don't do what is wrong. Another function is delivery services. But service delivery is service delivery. Another one is creating resources This can be human resource, they can be consumables that are required to run the system. Every, in quotes, sovereign country should be able to provide all the resources it requires. Now, financing is different from fairness in financial contribution. Financing looks at how money is done and how purchasing is done. So that's financing. I'm going to take time to explain all these functions to you, and then we can be able to construct what it looks like in different countries, especially in Nigeria. You know, we're going to construct what it looks like in different countries. I still have some time, so if you don't mind, I told you I'm staying till 9 o'clock, if you don't mind. Hello, class?
Yes, sir. Go ahead, sir.
All right.
Carry on, sir.
All right, thanks for your understanding. Okay, but I can assure you that this is the last slide I'm going to be running today. So we look at one of those functions, which is stewardship and governance. And in this, I'm going to define some of the key concepts. Governance. Governance are the rules or processes and the structure that guides decision-making, accountability, and stewardship in health. Healthcare is a regulated area. You don't just enter without going through certain things like registration, credentialing, you know, and ensuring that you will comply with all processes. Sometimes others, but yes, through professional councils or through the line ministries or through professional association and so on. Healthcare is regulated. In fact, even as a professional, you have a so strong sense of self-regulation where you want to ensure that nothing goes wrong with your practice. So when we talk about health system governance, according to the WHO, it means that it's a mechanism that ensures that strategic policy framework, effective oversight, regulation, and accountability, you know, are met. When you did ethics, I'm sure you know that God very important responsibility to secure the lives. The implication of that is that if you as a practitioner is engaged by a consumer for a specific service, the government is the witness. Both parties decide to bury the hatches, government may decide to pick an interest, and is picking that interest in order to ensure that there is decorum in the society. So if somebody comes in for a myomectomy, and then one thing led to the other, and there is mortality as a result of that, parties may not want it, but government has a responsibility to find out what's going on in that practice. And this is because the person or both parties, both the provider and the beneficiary or the patient, are the responsibility of government. Kindly confirm you're hearing me, please. I see a couple of signals.
We can hear you, sir.
Just
But your
confirm
voice
you're
is
hearing me.
breaking.
But your network is breaking. Your voice is
Yes,
breaking, sir.
it breaks.
Are you hearing me?
So your
It
network
keeps
is breaking.
breaking.
Okay. Yes, I see something displaying that my network is bad. Yeah, sorry about that. So that's governance. And leadership is one other aspect of the government or the stewardship function. And leadership is the ability to motivate people in order to be able to work with a sustained zeal towards achieving set goal. Looked at
So we've lost you again.
I've seen a very new challenge when it comes to it's often not the way
Please, we can't hear you, sir.
yeah. And that's the failure of MTN recently. Okay, so
For a
governance.
whole
So if you
minute, we
look
didn't
at
hear
all
you.
these domains, which has to do with intelligence gathering, the routine collection. You should be hearing me. I was off for a while, but I've gone. I'm sorry, but it's a network issue. Sorry, confirm you're hearing me, please. Hello?
Yes, Prof. Yes, Prof. We can hear you.
We can hear you, but
We can hear you now,
Yes,
but we
sir, we
missed
can
out
hear
on some
you.
of what you are saying.
We
But
can hear
since
you,
your
Prof.
voice has been breaking, sir.
I realize that, and I'm sorry about that. So if you look at the governance element, like intelligence is how we collect data, health data, system data, routinely. If you are in a system, you know that this needs to be reported from facility to local government to state, Ministry of Health to federal. And the importance of that is that they use those information, analyze the information, and take appropriate decision based on those information. That is why those information are called intelligent information, because you are using it to act. And then you look at the policy direction, the kind of tools they are using for implementation, the kind of structure and culture you have. It's a very big issue. So most times when people talk, oh, what are the problems of the health sector? You see them say, oh, infrastructure and personnel and all that. Sometimes people don't understand that one of the biggest problems of our health system or health service delivery is culture. The culture of the people, the culture of the healthcare workers. We run in a field where we see a lot of things happening, and most of the top players are medical doctors. And decisions are taken, and you ask, where are these decisions coming from? So culture is very important. Accountability is the ability to be answerable to various stakeholders. You know, sometimes we mention accountability, people just look at financial. No, the bigger aspect of accountability is how answerable are you? Are you doing what you're supposed to be doing? Are you carrying the stakeholders along? Relations and consumers. So all these factors have been shown to affect health outcome. So, talking about the governance again, I'm coming to the Nigerian context. We define governance as the system, the process in place to ensure that things go well. So you see that as in Nigeria, you see it at multi-levels. In health system governance, we have the global health system governance, which cuts across various countries. You have the national governance and you have the sub-national governance. Under the sub-national governance in Nigeria, you have the federal, the state, the local government. In some systems, you now have stronger ward governance, stronger community governance, and then the facility governance. All these are part of the sub-national systems. And so we see it play out in both at the executive level, the legislative level, and the judiciary. And within the health sector, you see the ministries which actually have oversight over all health issues in their jurisdiction, the departments, the agencies, the boards, the commissions that work with the ministry to ensure, you know, that things are done properly. Typically, in many states, apart from the ministry, you have the board to oversee tertiary healthcare. You have a board to oversee secondary healthcare. You have a board or an agency to oversee primary healthcare. Then you have another board to oversee insurance or financing of the health system. And sometimes you also have boards to oversee support systems. You know, there are a lot of support systems that need to be in place to ensure that the system is working. For example, you need infrastructure. Some states are beginning to establish infrastructure commission, you know, to ensure that all that is required infrastructure-wise with healthcare are provided. Some states are also beginning to set up health service commission. This is because of the uniqueness of the human resource within health. And so a health service commission is more appropriate to understand all this and ensure that they're able to curb, especially the current episode of brain drain in the country. So leadership and governance influence all other building blocks, as you can see on this slide. And when we're looking at the relationship between the building blocks, we saw that leadership and governance influence all of them. If you get leadership right, you're likely going to get all others right. So looking at the framework, domains, 6 domains of stewardship, the American Health Organization, essential public health functions, the World Bank's 6 basic aspects of governance. This gives you broadly what governance is all about, which is applicable to health as well. And the UNDP, United Nations Development Program's principles of good governance. These are 4 frameworks you need to know. I've explained that frameworks are there to help you understand concepts. So these 4 frameworks are important. What are the WHO stewardship and governance functions? One is to ensure strategic policy framework. The health system governance ensures that the right policies are in place. Nigeria started having health policy since 1988. So at the national level, we've got a national health policy, which was drafted in 1988. In 2004, it was revised. 2016, it's revised. But thankfully, Apart from the national health policy, there is a plethora of policy documents on virtually any aspect of healthcare in Nigeria as of today. There's a policy on mental health, there's a policy on eye health, there's a policy on all kinds of policies. The question is that, what about the implementation of the policy? Is a question many have been asking. Because apart from ensuring that the policy framework, the stewardship organs also ensures oversight. Oversight is the way of ensuring that everything that's happening within the health sector is controlled. Controlled in the sense that the health managers or the health governance system sees and ensures that parties are working on the rule of the game that have been set. So they also build coalition or consensus for health. They carry on regulation, they design systems, and they ensure accountability and transparency in the system. This is from the WHO 6 functions of stewards. Now, from the PAHO's essential public health function, you see 11 functions of governance. So where there are governance, you expect these functions to have been undertaken effectively. The World Bank looks at the clusters, which are the 3 clusters and 6 basic aspects of governance. Number 1 cluster is the processes by which those in authorities are selected and replaced. This is very important. Who are you appointing to a position? Are they those who are considered fit for the job? We know that in Nigeria, as of today, many appointments are politically done. And as such, you may not get the right people in the right places. If you have the wrong person in the right place, or you have the right person in the wrong place, you're going to have a challenge. And most of the time, this is what plays out. So once that is not done, it means that there won't be accountability in the system. People will not have a voice. So when it comes to selection, in most instances, where people have a voice is where they can be part of the system of selection. In an organization, for example, the CEO is retiring, the people have a voice. Sometimes the civil servant will tell you that the highest serving civil servant should be. That's not in the best interest of that organization. The highest salary may not have what it takes to lead that organization. The closest way to do that is a merit-based selection of heads. A merit-based selection could be done by an external parties that are experts in ensuring that they're able to match people's quality to job requirements. And we see that play out in many countries. I've seen an advert some years ago advertising for the government of Bosnia Herzegovina, and they were looking for a special advisor on health. And this was placed on an international advert. And so if people apply, which a friend of mine applied, they got a firm, an independent firm, to screen all the applicants. And they had very strong, rigid screening system, including psychometric analysis. And as such, they were able to screen and got the right candidate who was not a citizen of that country, was a Canadian that won that job. You understand? So we can imagine that if you want your system to work, like the late Dora Akunyili said, you need good people to have a great nation. So voice and accountability is very important. And if that is not done, you have a lot of political instability and violence, including fight for authority, for positions within the system. Another cluster is the ability of government to formulate and implement sound policies It has to look at basic aspect of government effectiveness and also regulatory burden. A third aspect is respect for citizens and for institutions, and that has to do with rule of law and the control of graft. Graft is corruption. How does the system strive or strove to control corruption? The UNDP 5 principle of good governance looks at, now you see, if you understand the World Bank cluster, you see that it's almost the same thing. Legitimacy and voice looks at the issue of processes whereby people in authority are selected and replaced, and that has to do with participation, consensus. Direction has to do with the issue of formulating policies and implementing that. And then you see the issue of performance, accountability, fairness. And so generally, on the principle of governance, we see governance systems are established to provide all this, the strategic vision, forum for participation, rule of law, as the case may be. In many systems, like I did explain, and state subnational systems in Nigeria, you have structures. You have the State Ministry of Health. For service delivery, you have a structure. But for quality and patient safety, there's almost none. Health financing, some states have got a state social insurance scheme, others have not. Workforce, the Health Service Commission, just in a few states like Lagos. The commodity and infrastructure, we see many states do not have it. Information and research to support research like we see in developed countries like the National Institutes for Health or the National Institute for Health Research, the Canadian Institute for Health. And many countries have similarities. We have the Nigerian Institute for Medical Research, but they did not take on the function like all these other national institutes. In fact, the Medical Research Council also looks for funding to do their work. They do not coordinate research related to health as it's expected to be, maybe except that it's reformed. So yeah, we have seen that play out. When we come to the Nigerian health system, we'll talk more about the governance within the Nigerian health system. At this point, I want to know if there are questions or comments. This is a discussion on the things we have learned. And then if not, we'll call it a day. Any question or comment? Hello? All good? All good?
Yes, sir.
Yes, sir. All
Yes,
good.
sir.
Yes,
Yes,
sir.
sir.
All good.
All right, so let me appreciate every one of you for your audience. It's been a wonderful class. The next encounter we have is on the timetable. We'll make well to cover up a few things we may not have been able to do in this class. So thank you once more and enjoy the rest of your evening.
Thank you,
Bye-bye.
Prof. Good night.
Thank you,
Thank
Prof.
you, Prof.
Thank you,
Thank you, Prof.
Prof.
Nice, Prof.
Have a good night.
Thank you.
Thank you.
Good night, Prof.
Thank you, Prof.
Good night, Prof.
Thank you, Prof.
Not the show green.
Good night, Prof.
Yeah.
Thank you, sir.